with you. As always, you will be muted and your video camera will be off as you join the session, but we do invite your participation in the chat, so please direct your questions to all panelists, and then we will be sure to get your questions answered if we have time at the end of the presentation. And we always, as always, appreciate your feedback at the end of the presentation following the instructions on your screen as you close the WebEx. For those of you who are looking for educational credit this morning, if you've joined us for more than 45 minutes, you will get a certificate of participation that will be sent to you automatically next week. If you have missed any previous Grand Rounds, you can find them in our Grand Rounds online library by following the instructions on your screen. And if you would like to be sure to not miss an upcoming Grand Rounds, you can email us and we will add you to our email distribution list and send you a calendar appointment. We invite you to join us next week for Grand Rounds with Ed Morales, who is a social worker here at Children's Minnesota, but also does work with the Minnesota Department of Health. He's really going to be talking about child protection and how we approach child protection with an equity lens. For those of you who joined us last year, we hosted Nikki Farrago from the Department of Health talking about the historical trauma experienced by people of color in the child welfare system, and she really went through quite an informative Grand Rounds about that topic. And what we've asked Ed to do is kind of a part 2 of that talk. So he's going to take that information and then really give us some tools for how we apply knowing that history to our work with patients and families today. We invite you to join us at our Talking Pediatrics podcast that releases every Friday. This Friday we will be talking with Dr. Gabby Hester about MIS-C. There are some new MIS-C pediatric guidelines that were released by Children's Minnesota, so we'll be talking about everything you need to know, whether it's in an inpatient or outpatient setting, for caring for patients who have suspected MIS-C, and we'll run through those guidelines this Friday. And now I have the pleasure of introducing our esteemed presenter this morning. Many of you know Nurse Practitioner Patsy Stinchfield, who is a board-certified pediatric nurse practitioner and who is our Senior Director of Infection Prevention and Control and our COVID incident commander here at Children's Minnesota. I'm just going to hold up to the screen Patsy's lengthy bio here, so if anyone wants to screenshot it and read it later, you certainly can. But I know that Patsy has a lot of information to share with us this morning, so rather than reading through that, I am going to let her go ahead and get started. Patsy, thank you for joining us.
Great. Thanks so much. Hello, everybody, and here we are into this major anniversary of the pandemic. I hope everyone has stayed safe and strong throughout this all, but we're going to start with some trends, some major epidemiologic trends and milestones. And first with saying I had the pleasure of being part of the ACIP meeting yesterday virtually, and we were joined by our new CDC director who asked us to say thank you to all of you. Thank you for the care that you give to children every day and the hard work that we do in the pandemic here at home in the community. She asked us to hang in there. Vaccines are on the way. Testing is on the way. Her name is Dr. Rochelle Walensky. She's the a former chief of infectious disease at Mass General, professor of medicine at Harvard. Very smart woman, very well respected by the CDC, and you could feel the difference that science is back. So really happy about that. So let's just start with a little bit of global look here. 1 year later, here we are, over 100 million cases and over 2 million deaths globally. We passed those milestones just this week. You can see here from the darker colors that are greater than 300 per 100,000 population, and that includes the U.S. So we have a ways to go before we are out of this. And 1 year later, for the United States, we've had 25 million documented cases in the U.S., over 67,000 new infections per day average, and a new infection about every 1.2 seconds. And so January has been our highest month here, and over 417,000 deaths. And the projection is at the rate that we're going that we'll be up over 569,000 deaths by May. And so over 4,000 deaths per day. So you feel already a little, that was really high, saying hello from the CDC director, now this is really low. I'm afraid to say this talk does have some good news and bad news throughout, so it's a bit of a roller coaster here. But we are, you can see here, those people who may think this is a hoax, it is not a hoax. We have COVID as the leading cause of death in the United States, and you can see that in 2021, all those red marks there are deaths beyond the average, and those are related to the coronavirus. So CDC infections by county, you can really see this is, infections are very local, and it's not really just about a state. It can be about what part of the state is really having the issues here. So we're happy to really be at this point now in Minnesota in that lighter color, which means fewer cases. And but we do see that some good news here. While we just experienced our peak of the entire pandemic in January, the trends are pretty good here. So you can see November climbing up, a little drop down in December, climbing up again late December, and then dropping down. So we've dropped down to where we dropped down twice before, and then it climbed back up. So we're at kind of a really pivotal point here. And I'm hoping that that arrow, that line can just continue to go down, but how it goes down is because of us, because of our behaviors, mask wearing, because of getting vaccination, et cetera. So we really are at kind of a crossroads here and are hoping that that is the beginning of a very deep downward slide. The deaths really is kind of a sad trajectory of upward there. You can see we dropped down in like early January, but we've climbed up and are sort of still relatively high, 416 deaths, and I think we're at the highest that we've been since the beginning of the pandemic. So again, sort of good news and bad news. Now here's a good news slide. I am very thrilled to see that Minnesota's percent positivity, which I think is a really important number for all of us to follow, it is the marker of what we can do. And I think the mistake the United States has made is we've gotten to this sort of low percent, and then we say, yay, let's open up this, that, and the other. And instead, what we need to do is get that single digit down even lower, as close to 0% positive for as long as we can, and then consider opening up. So if we're in a really good spot right now, if we can just get more vaccine and get that supply and keep our percent positive low, increase our immunity by way of vaccination, that would be a really great spot to be in. The entire country needs to look like that, and you can see that the rest of the country is not quite as fortunate as we are. That darker blue is in any double digits, 11 to 20% positive. So keep your eye on that number. I think schools are using that as well. So when you look at the news, it's sort of like you work all day on this, and then the news is on it all night, and I think we all feel like we just can never get away from it. But hearing about what are tracking the coronavirus in Minnesota, the Star Tribune saying there could be some nasty surprises circulating, and then the very next day, right where my picture is there, the Brazil variant became the first in the United States, was discovered, was found here in Minnesota. And I'll talk about that in a minute. So let's just go into variants here. So variants, as Dr. Tony Fauci says, viruses don't mutate unless they replicate, and that's what they exist to do, is replicate. And they replicate because there's not herd immunity. So if you've got vulnerable people that you can infect, that you can replicate, it will do that, and then those individuals infect others, and then they replicate, et cetera. And so it's in outside pressures of what makes viruses change and replicate. Sometimes it is, partial immunity. Sometimes it is environmental factors, et cetera. So, but it is not, the fact that there are variants is not the issue. It's what the variants are and how they're behaving. So we expect that viruses will change and mutate over time. Within 2 weeks of the Wuhan virus, it was had already mutated. So you'll see this legend here on the lower left corner. This is variant of concern, VOC. You might also see VUI, variant under investigation, to see, how worrisome is this variant? Has it changed enough to make us say, ooh, our vaccines may not be good enough against it? Is it a minor variant or mutation that doesn't really change anything? And if you think of other viruses, such as influenza, that is such a complicated virus and it changes so regularly that we have to be revaccinated every year. Whereas measles mutates as well, but it mutates so small, such a small amount that it doesn't evade our MMR vaccine. And so that's the kind of measure that we're watching here. So you can see in the blue the South African variant there, and then throughout Brazil, and then the UK variant also is seen now in Canada and elsewhere. So you've heard mostly about this B117 variant, and this is the U.S. map. This was just updated yesterday, so I included it for you here. Minnesota's up to now 8 tested cases. That's those that we know of by way of surveillance. That the biggest states are California and Florida, where they have 92 in both of those states. New York has 22. Most of the rest of those states have maybe 1 or 2 cases. So we're sort of in the middle here, but it probably is throughout most of the U.S., and we'll be seeing more about this. So what happens when we're talking about mutations? You really, again, focus on that crown part of the coronavirus, that spike. It's the spike protein mutations where there'll be amino acids that change a little bit. Sometimes they're deleted, sometimes they're added, sometimes they just physically change so that they can bind better to the receptor cells, but that's what we keep our eye on, is those spike proteins. So here's just a little graph of what you've been hearing more about. There also is a California, newly emerging California variant that they just recognized as a novel variant, and perhaps is why California has had such a tremendously difficult time of late. So if you look across, these are the questions on the left-hand column here. Is it more contagious? Typically, they do become more transmissible or more contagious. Typically, viruses, when they do that, they don't get more virulent or more deadly, and we're not seeing that per se. But because they are more contagious, where, for example, with our original U.S. strain, that you would have one person infect 2 others, now one person is infecting 4 others, and then those 4 are each infecting 4 others. And so the contagiousness really is, the trouble is that we may end up having more and more cases who have previously had coronavirus, who maybe are not recognizing this variant, get it again, and it's really the worry about our hospitals being full again. And so is it deadlier? Well, coronavirus is deadly, and so it would do the same thing for that older age group, et cetera. So that's what is concerning us, why we're watching that. Is it going to evade tests? And I want to give a shout out to Julie Laramie in our lab. She is really, and Deb Garten and team are really following this closely. So if you're doing a PCR test looking for coronavirus, you're looking for certain genes, and if the mutation is such that it evades the test, you're going to get some false negatives. And so they're watching this closely. They're working with the various manufacturers, and this is happening in a couple of PCR tests, but none of the ones that Children's uses. And so we're watching that closely. We will be posting, if you want to dig down into this and some of the references related to PCR testing and variants, it'll be on the COVID page by the end of today. And then I guess the biggest question we all have is, will these variants evade the vaccines? And so what they do is they take antibodies from people who have been vaccinated, and then they introduce it to these variant strains and see what happens. And so far, both the Brazilian and the UK strains seem to be diminished a little bit. The UK strain especially, and I love Dr. Fauci's word. He calls it a cushion. It is diminished somewhat, but not to the point where it's not protective. That we do have this sort of immunologic cushion there. However, the South African, it's that E484K mutation, that seems to be what might be evading especially the Moderna product. So, which means that you could have had prior disease, you could have had a prior Moderna vaccine, and you are introduced to this mutation and you get sick again. What is good about the messenger RNA vaccines is that you take that mutation and you make it again new, and you know how quickly those can be made compared to live virus vaccines and things like that. So it is possible that there may need to be in places like South Africa, where this is now becoming the dominant strain, that they will have to have a booster after their 2 doses of the Moderna vaccine, a booster that then covers this mutation. Not such good news, but those are the kinds of things that we're really keeping our eye on. So just a reminder of what this virus, this beast of a virus, does as it enters here. These spike proteins then, around that, the virus there enters into us by way of this ACE2 receptor. And so one of the thoughts with these variants is that process right there where the spike protein reaches into our ACE2 receptor is that it is more agile and able to do that. So there's better binding, easier receptors, maybe perhaps more spike proteins that are able to bind with the ACE2 receptors. Therefore, you've got more virus entering into the cell. And then, of course, an increased viral load is very possible as well. As that gets in there, then the RNA it makes more proteins, then goes back out onto the surface of the cell. The copies are made, and then again continues to replicate in the cell, primarily in the respiratory system. So it's really targeting, looking at that spike protein and understanding its function. So the implications for vaccines, and this is, many of these slides are from our CDC meeting yesterday. They're public information. It's posted on their website, and the whole thing is very transparent. You can listen to the conversation if you want to. I wanted to share this with you because all of the preprints and on the topic of variants are on this slide, and so it's very helpful reference and resource here. But again, so far with the Pfizer-BioNTech COVID-19 vaccine that we are using here at Children's, it seems that several of the studies have demonstrated equivalent neutralizing titers against these various variants. So, so far it just seems, as I said, to be the South African strain that is a little bit worrisome for the Moderna vaccine. So we'll keep our eye on that, and more to come. All right, so what the WHO is saying, you know, they're really watching this closely worldwide. And again, if one person in the world is dealing with coronavirus outbreaks, the whole world needs to pay attention to that. So we will be watching this, and what they've done is increase their surveillance. So more molecular testing will be sent in by countries and certainly by states to the CDC. And I hate to say this, but the United States is one of the lower countries that has an ability to do increased surveillance. So the UK is kind of the leader. I think they have an ability to do surveillance, this genomic sequencing on nearly half of their specimens, and we're more in the 4%. And so it's timely and costly, and it takes a few days to get this information back, but we really need increased public health funding to be able to do more of the surveillance at the states and then collaborating with CDC. So we'll also accelerate that collaborative research across the world, looking at the vaccine questions that are unanswered and how the variants may impact them. World travel considerations are certainly being discussed at the WHO and in countries, and many countries have put a travel ban on from where these viruses are most predominant. The WHO is trying to get away from calling it the Brazil strain or the South African strain and using more of that variant number because sort of like the Spanish flu, the Spanish influenza pandemic did not start in Spain, it started in Kansas. So we should be calling it the Great Kansas Influenza Outbreak, but typically it gets named after where it emerges later on. So what we're going to do is with these variants is continue to focus on the gaps. You know, does it evade the antibody treatments? And some of our monoclonal antibodies are very much designed towards the circulating strain, and so there is very likely that we're going to need to make some modifications to our antibody treatments. Again, we're watching our molecular testing, watching for those false negatives, and so far at Children's that seems to be okay, and we'll be watching the impact on vaccines. So speaking of travel, this just came out yesterday from the CDC where this international travel does really require us to pay attention with the variants. And when you look at those 8 individuals in Minnesota who had that B117 variant, they all had a travel history. They all were mildly ill. They were not hospitalized. They all did fine, but they had travel history, mostly to Brazil, to California, and Europe, I believe. So there is a new guidance from the CDC that just came out, and basically, if you're traveling internationally, and I'm going to say they're requiring this for international travel and strongly asking people to consider it for U.S. travel. So if you get on an airplane, this is what they are interested in doing. We'll be meeting about this because it just came out yesterday and posting it on our COVID page and communicating with people. But if you're doing international travel, here's what will be required. Test negative 1 to 3 days prior to departing from the country that you're in for home. Before you come back to Minnesota, you'd have to be tested in that country and test negative or have an attestation letter that you've had COVID. When you arrive back in Minnesota, you would have to be tested 3 to 5 days after arrival and quarantine for at least 7 days. If you're not tested, they want you to quarantine for 10 days, and regardless of testing, they want you to avoid high-risk people for 14 days after international travel. You know, international travel is just really sort of you don't know who you're walking by or sitting next to or wherever and what country people come from. They bring their viruses, and the virus does not really care where we live or where we're traveling to. It just cares if someone is not immune. So let's just dig down a little bit more into the vaccine status here. And I'm going to, instead of global, I'm going to focus on one country, and that's Israel. The United States, Minnesota, and Children's on what our vaccine status is. So why did I pick Israel? I picked Israel because they are leading the way in the distribution of the vaccine, and it is kind of a cool story. I would just ask you to Google the CEO of the Pfizer-BioNTech vaccine. Is the child of 2 parents who were Holocaust survivors and grew up hearing about the millions that were lost in the Holocaust and really committed his life to figuring out a way of how he could make that up in saving other people's lives. And boy, did he ever do that well. So getting to become the CEO of Pfizer and developing a pandemic vaccine in record time, Israel did get some of the doses first, and they have a little bit of a head start on the rest of the world in vaccinating. Israel is about the size of Michigan in terms of population, and so it's really quite a great story if you want to read about that. So what they're doing, though, in Israel is they're asking, how fast can vaccination against COVID-19 make a difference? So this was a really interesting report in Science and Technology. And what they're doing is they're measuring both the direct and the indirect effect will take time after the masses are done. And so Israel, by January 19th, within 1 month of vaccinating, they had 26% of their 9 million population vaccinated, again, about the size of Michigan. There were 200,000 vaccinated subjects and over 60 being followed by this research institute in Tel Aviv. They compared it to another 200,000 unvaccinated, so really big numbers of people in this trial. Within 12 days, they didn't really notice a difference between the vaccinated and the unvaccinated. But by day 13, the test positive started to fall in the vaccinated group. After 14 days, and remember that's what we say, when is my antibody levels at a protective level? We say about 2 weeks. And in this study, after 14 days, that test positivity had dropped by 30% in the vaccinated group. And at this trajectory, their deaths will be down substantially by early March. So very exciting to see that. And then you can see also on the left-hand corner here where they looked at Israel, the change in the critically ill COVID-19 patients from the prior week by age. So as they began their vaccination, they saw a significant drop, and especially in the 60 and over. So that's really encouraging news, I think, and a nice study to show vaccines work. So you remember this from the last time we met, just how is the U.S. rolling out? We've got this phase 1, and at the bottom there where we are just about finished in Minnesota with our healthcare professionals, our long-term care residents are almost 90% vaccinated. Sadly, we're having trouble with the healthcare workers in long-term care. There's a fair amount of refusal. I think we need to do a lot more creative communication and outreach to them. Many of them are newcomers to Minnesota, people of color. They have fears and really need just some special outreach. We're moving on in Minnesota to 1B, the essential workers, and the governor has chosen to focus on teachers, and so there will be a 5-day event in St. Paul that will have teachers. The number of teachers that need to be vaccinated far outpaces the supply that we have, but it'll be a good mass vaccination plan to see how that can work when we get to phase 1C, which is the general population, others with medical conditions. So this is just a map of how we're doing and the number of people who've received 2 doses per 100,000 population. And so you can see North Dakota is in that greater than 2,000, but their population is certainly not as dense as some other states. And so we're kind of in the middle of the pack there, and we'll continue to monitor that. Well, let's just move then to children's. How are we doing with our employee vaccine surveillance? So I want to thank my awesome EPI team, Leah Johnson, Joe Curlin, and Julie LeBlanc for putting this together for us. So we have vaccinated over 6,000 people, 6,207. 4,000 have had their first dose, and over 2,000 have had their second dose. Some have had it in external facilities. And if this is you, please go on StarNet and go to your go to Applications COVID, and then just let us know that you were vaccinated elsewhere. Put your CE number in again, and we will keep that count. So that's really helpful. And so here's where we are with our staff. Really, we're basically down to about 10% of people have declined, 11% who have declined, and some of those people probably will get vaccinated later. They may have declined for reasons right now. Maybe they were acutely sick, or maybe they're not like early adopters. They want to kind of watch and see how it goes for the rest of us. There's a fair number of people like that. And then there's 10% that didn't respond. So we are reaching back out to people to say, hey, are you going to come back in? So that either between children's or elsewhere or having had recent COVID, we're upwards approaching 80% of our nearly 5,000 people that are vaccinated. So very proud of that and not surprised. We have very high flu vaccine rates, and I knew we would come through for this as well. what kind of side effects are we seeing at children? So the COVID vaccine does have, you can call them side effects. There's an effect. It builds your immune response, and sometimes there's a side effect. You get an effect that you don't want. But basically what that is your immune response recognizing the antigen. So what this data covers are those who reported symptoms to Children's Employee Health Services. So there are likely people out there who have had some of these things who did not report to EHS, very likely. And so this is only the people that we know about, those who called. And so it's symptom onset with 1 to 7 days of vaccine administration, and the day you get your vaccine we count as day 1. And so this is between our very first day, December 26th, and yesterday. So, okay, so what we are seeing is the after dose 1, it's about 1.5% of those that are vaccinated are reporting side effects to employee health after their first dose. So not that 1.5% have any symptoms, but 1.5% that have symptoms enough to call employee health. But nevertheless, that's still a relatively low number considering how many people we're vaccinating. And interestingly, headache seems to be the leading side effect that people are calling about, and I'm hearing that it is a pretty intense headache. Fatigue follows, body aches, some with fever, nausea, vomiting, chills, and then you can see as it goes down, rash is on here too. And notice loss of sense of smell and loss of taste. So, what does that mean? We'll talk about that in a minute. And here's what we see with dose 2. Muscle aches, body aches seems to be right up there now with headache, fatigue, chills, fever, nausea, vomiting. And so mostly this is, when you think about it, it's kind of when you have that feeling of, oh, I feel like I'm coming down with something, or I feel like I'm getting sick. That's really what's happening, is your immune system recognizing that antigen, doing all of that it does in such a miraculous way with building your B cells and T cells, responding, filing this away so that if you ever do encounter the actual SARS-CoV-2, those antibodies that have been built will be called out and you will be protected. So while this does not look good to have body aches and headache, it certainly is far better to have this for a day or two than to be on a ventilator in the ICU with coronavirus disease. So when you look at this list here, the common symptoms, and you can see kind of tucked in the middle of this paragraph here, loss of sense of smell and loss of taste, that is not really a post-vaccine a side effect that we would expect. And so what it tells us is people do get coronavirus even in the process of getting vaccinated. That's why we've been very careful about keeping 6 feet apart, making sure that we've had our schedule, that we don't get people clumped up too much because we don't want them being exposed. And sure enough, it looks like we have had people come to the vaccine clinic who actually had COVID developing. So typically, when they're after dose 1, that symptom onset is about a day and a half or so, and can be out to 1 to 7 days. And dose 2 can be also, again, out 1 to 7 days, but the mean and median is a day after. So what are we seeing? We've seen 5 employees that tested positive for SARS-CoV-2 1 to 14 days after their vaccination. So loss of sense of taste and smell is not a vaccine side effect. It is a well-known symptom of SARS-CoV-2 infection. And so likely what happened was someone was exposed and before they came to the vaccine clinic, they got their vaccine, and there is no increased symptoms or problems with them if they were in developing SARS-CoV-2 infection at the time that they got vaccinated. That is okay. That's why we don't swab people and to see if they're positive at the time. We don't do antibody testing. There really isn't a physiologic need to do that. So we have had some significant employee events. We get to wait with you for 15 to 30 minutes afterwards, and we've had about 15 people who had a number of things. Some have had angioedema, some have had a little bit of hyperventilation. There's needle phobia. We've had some vasovagal. We've had one person who required an ED visit who had hypertension, and I think that coming into the vaccine clinic just made the blood pressure go even higher and high to the level of needed some medical attention. Nobody has been hospitalized, and that blood pressure event and then another long-term angioedema, just a rash that would not relent, but not airway involved. Those were both reported to VAERS, the Vaccine Adverse Event Reporting System. So we are seeing that more employees are reporting their symptoms after dose 2. About 51 employees, or 38%, have needed to have a day of PTO after the vaccination. And that is, again, they call employee health, they talk over their symptoms, and realize that you've got fever, you can't work tomorrow, or you've got body aches that are keeping you in bed, you won't be able to work. All right, so let's go through some updates from ACIP. This was yesterday, the Advisory Committee on Immunization Practices. I'm a liaison member, one of about 40 people at this meeting. I represent NAPNAP, the National Association of Nurse Practitioners, and it gives me this firsthand information here, so I'm very happy about that. In the past, I have covered the messenger RNA platforms, both Moderna and the Pfizer-BioNTech vaccines. Coming up will be 2 new platforms, these adenovirus vector vaccines. So the Janssen, made by Johnson & Johnson, is an adenovirus vector vaccine, and that is a human adenovirus. Ad26 is what they call it, and it is a vector. So basically, you take a virus that is not a threat to you, it can't make you sick, they sort of modify it so it won't give you adenovirus, but your body recognizes it, takes it in, and it's kind of, they basically put the genetic structure of SARS-CoV-2 spike proteins, and it acts as a Trojan horse, and so comes into your body and then makes protective antibodies against that. And then the Oxford COVID-19 vaccine, the AstraZeneca, is a chimpanzee adenovirus vector. That is also being used. It's been used in other vaccine platforms as well. So most people, of course, have not spent any time around chimpanzees and so don't have antibodies to adenovirus, whereas many of us have been around human adenovirus, Ad26, and so that's one of the things we're going to be doing is looking at the difference between these adenoviruses to see if people have had adenovirus before, will they not respond as well? Will they respond better? There's some interesting questions there. So yesterday we heard about the AstraZeneca. In the future, in the next, I would say, couple of weeks, we're going to get the Johnson & Johnson data out. We'll bring that back to you either by way of the podcast or in another mode. We're looking forward to Johnson & Johnson because it's a one-dose vaccine, and we hope it has really high antibodies. But today I'll go over the AstraZeneca. You can see the technology here. Again, it's the non-replicating chimp adenovirus vectored vaccine, and it expresses the COVID-19 spike proteins. And the chimp adenovirus really avoids that issues with pre-existing immunity to human adenovirus. It makes strong B cells and T cells, and is in this data is in our interim data in phase 1 and 2. One good thing about this trial is very international, very diverse group of people that are in this, and you can see that it's being studied in places where we have variants, and so we're really interested to see. You can see in Brazil, in South Africa, California, etc. So we'll see how that does. And here's their diversity profile of the people that were enrolled, and we would certainly like to see this higher, but there is a lot of dedication to this in all of the clinical trials to try to enroll people of color. I honor my own colleague, Adrienne Thornton, as she and her daughter are in the AstraZeneca trial here in Minnesota, and that is exactly what we need, is for people to step up, and we appreciate that so much. They're looking also at age groups and then whether or not people had comorbidities, obesity, hypertension, et cetera. So this is the summary of phase 3 interim pooled efficacy. This is in that diverse cohort, both internationally and ethnically. The pooled analysis demonstrated about a 70.4% efficacy at preventing symptomatic COVID-19, and that was the endpoint, to prevent symptomatic COVID-19. Now, I can kind of hear people go, 70.4%. Well, if this had been the first result out, we would have been cheering, because we were hoping to be at least as good as influenza vaccine, which is anywhere between 30 and 60%. So we would have thought this was tremendous. But now we've gotten pretty spoiled with our messenger RNA vaccines up in the 94, 95% return. So this seems to be a safe vaccine. There were no hospitalizations or severe COVID-19 in vaccinated participants 21 days after the first dose. So the CDC work group looked at it. They looked at the phase 1 and 2 studies. They looked at the global phase 3 studies. They did have a hold on this. If you remember, there was a pause. There was one individual that got transverse myelitis in the UK, and which can happen from other viral infections, and so they did not think that was any reason to stop the trial. And the profile is very similar: arm pain, feeling feverish, muscle ache, and just the usual sort of immune responses. No serious adverse events were reported. All right, so let's get into pediatrics a little bit here in our remaining time. So COVID-19 in the age groups, as we know, in children, we just are not seeing this as much. That 0 to 4-year-old and the 5 to 17-year-old are really much different than the older adults, 18, and then, of course, up in those who are older, 85 plus, are really probably the most impacted. But we have to talk a little bit about the our 20-year-olds. You know, when you look at that age group of the 20-year-old decade, they really are, in every way that you look at this, they are most commonly infected. And, you know, is that because of behavior? Is it because of testing? Is it, you know, it's hard to know what that is, but that's a really important population that I'm looking forward to getting vaccinated as well. This is looking at if you estimated SARS-CoV-2 infection rates per 100,000 population and adjusting it for under-detection. So we think that children, you know, well, we know that more than half of all COVID infections are asymptomatic. And when you look at children, they often are asymptomatic or have such mild symptoms that you wouldn't even think to bring them in for testing. So they've modeled this here for us and calculated out if we were to try to account for under-detection, you would see probably a little bit closer to the 5 to 17-year-olds, up closer to that 18, 20-year-olds, and that a higher rate in that 0 to 4-year-olds as well. So when we look at, this was a study that they shared from Mississippi looking at seroprevalence in those under 18. And when they looked at the race and ethnicity, you can see just the percent positive, the highest in Hispanic and also Black, non-Hispanic, where white were just 5.3%. And then when you look below on those dates, you can just see over time those percentages increasing. And so certainly there, you know, children do get SARS-CoV-2 infections. Children of color, like adults, get it in a disproportionate way. This was a household transmission study looking at Tennessee and Wisconsin. Basically, the red are the infected folks, and the other people are non-infected, and they looked at how they were presenting, what kind of symptoms did they have in the different households and different ages. And so younger children were less likely to be symptomatic and had fewer symptoms than adults. And I think, you know, this has been documented again and again. And when you look at the sort of darkest bar is the less than 12-year-olds. The purple bar is the greater than 18-year-olds, and that other middle bar is the 12 to 17-year-olds. So you know, those who had no infections, it was highest in the young children. Fever was highest in young children. But all the rest of these young children really are not the ones that are leading the way in the kinds of symptoms that they're having. So that is one of the problems with this disease, is that you can spread it and not even know that you have that infection. That's what makes it different than SARS-1, where they did not transmit until they were infectious. Again, just showing here that, those secondary infection rates, symptomatic children seem to transmit far less than the adults. If you look at the bottom there, the 65 and over, how the percent transmission of secondary infections that they had are much, much higher than those that are less than 12. So, you can use this data as you think about your child going back to school and the kinds of activities that they're doing, et cetera. And then just looking at how sick do children get with COVID-19, and the hospitalizations here have really not changed throughout. These are week by week, and that 0 to 4, 5 to 17, as we know here at Children's, we certainly have taken care of, had hundreds of admissions, but not like in the older age group where it's thousands. So there's always been a question about do kids with underlying diseases do worse or have more problems, more severe illness with COVID-19, and it does seem that there are some conditions that, have a greater potential. So asthma, diabetes, genetic or neurologic metabolic disorders, sickle cell disease, heart disease, especially congenital heart disease, immunosuppression, medically complex kids, and obesity. So when you think about who gets influenza, worse, it's the same population as well. So when you, let's just look at this, the obesity is just a phenomenal impact both for children and adults. 52% of children less than 18 who were hospitalized, what underlying conditions did they have? And obesity was really quite prominent. And then also, how severe are they? So intensive care unit, this is again 0 to 4, 5 to 17 in the blue, and then all ages in that darker gray. All pretty even about intensive care, but far less mechanical ventilation for young children, and certainly far greater death in older adults. So while we know that children do get COVID-19 and they can die of it, but they die at very, very low rates here. For 0 to 4, it's 0.4, and 5 to 17-year-olds is 0.3. And so that is in the good news column for sure. All right, so this is looking at just my only slide today because we have so many great experts on MIS-C. I'll just give the epidemiology of it. So the multi-inflammatory syndrome in children, MIS-C, we are at Children's Minnesota has, I think, seen the vast majority of kids in our state. I think all but 10 cases have been seen by our infectious disease and immunology and ICU teams here, so thank you for your great work. There have been 26 deaths in the U.S. from MIS-C of the 1659 cases. They have been predominantly an average age of 8-year-old, 57% male, and again, a third Hispanic and 30% Black. And so we will keep our eye on that. We are also hearing more about MIS-A. Do adults get a multi-inflammatory syndrome? It's a little bit harder to parse out because they have some underlying cardiac disease, et cetera, that can make the diagnosis challenging. But more and more, it seems like that is possible. So in summary, for children, greater than 24 million cases of COVID-19 and greater than 410,000 associated deaths were reported in the United States, and this is population overall. For children less than 18, they have the lower rates of COVID incidence, hospitalization, and mortality. They are susceptible, though younger children tend to have fewer respiratory symptoms than adults. MIS-C is the complication of COVID-19 in children. It has very varied clinical presentations. It's also the highest and disproportionately so among Black, African American, Hispanic, Latino children, which just really brings the point home again about we've got to do a better job in communicating and vaccinating this population because they are so absolutely high risk at every age. And so further studies looking at the role of children and teens in transmission is important. So where are we at with vaccinating children? So this is, I was just so happy to see it on the agenda, and both I and a person from AAP expressed that we just really need to go continue with this. 25% of our population are children, and so if we want to get out of this pandemic, we got to make sure that they're getting vaccinated as well. The pediatric burden of disease is significant. We want to make sure that we don't just wait for natural herd immunity, and that we've got safety trials. The interesting letter here to, it was, let's see, I think it was IDSA's paper, Warp Speed for COVID-19 Vaccines, Why Are Children Stuck in Neutral? And I think my friend Buddy Creech probably came up with that title. Oh, and by the way, Operation Warp Speed is going away. They're going to give it a new name. All the same people will be working on it, but they're not calling it that anymore. And so when you look at the top column here, COVID-19 and deaths, 185 children, less than 18 years, and then you compare it to other diseases for which we already have a vaccine: varicella, 50, rubella, 17, hepatitis A, 3 deaths, rotavirus, up to 60 children per year deaths, influenza, as we know, 192. I think there's only been 1 influenza death in the U.S. this year. Normally there's a couple hundred. But there are vaccines in clinical development. It's very exciting. You can see the manufacturers across the top, and you can see the platforms that they're using. Most of these are going to be in a couple of doses, at least 3 to 4 weeks apart. Moderna is doing a very focused teen cove, 12 to 16-year-old. And currently they have a license for 18 and up, but they're really doing a separate study just on those kids. And I know we've got some of our employees here at Children's who've enrolled their kids, and we really do appreciate that. So this is hopeful. We've got 4 different approaches here. I know the AstraZeneca pediatric trial is going on in the UK, and they've enrolled quite a few people already. And so the way that you get a vaccine for children in a pandemic like this is you do what Pfizer-BioNTech has already done. They studied it in 18 and over, but they asked for a license in 16 and over, with the case that immunologically 16-year-old and 18-year-olds are the same, and that's what it got licensed as. Or you do a standalone trial like the Moderna Teen Cove, or you do this expanded age eligibility. So here's Moderna's trial. They basically bring you in for these different visits, and you're in either the placebo group or the vaccine group, and it's a 2-to-1, so there'll be 2,000 people getting the vaccine and 1,000 getting the placebo. They are doing nasal swabs before each vaccine, which I think will help with the transmissibility question. They're doing blood work as well. And then the other way is that you do this this is an example, it's not underway yet, but it is being planned right now, where you do this dose ranging study and you say, okay, well, let's say we'll take it in the 6 to 12-year-old and we'll give them a full dose and see how they do. And then you move it down to the middle column there, the 2 to less than 6-year-old. You start with a half dose. If they do okay with the safety review, you move them up to a full dose. And then you move it down to infants and 2-year-olds, and you start them with a quarter dose safety review, then go to half dose safety review, and then full dose. Kids may make good antibodies with just a half a dose and have less reactions. And so the dose, the safety, and then does it work and build antibodies is what we do in those age groups. So basically the overall is that we want to continue the clinical trials for safety and immunogenicity are really essential. One little tidbit from yesterday, because I get asked this question a lot, is if I'm going to get my dose 2 on my current COVID vaccine, does it have to be on day 21? You want to be as close to that as possible, but is there an outer limit? And yesterday they did say they want people to get that done within 6 weeks or 42 days from the first dose, just to be able to say that you're following as close to the science as possible. So on December 26th, we were happy to bring in people to vaccinate them. We've established the V-Safe program. People get the little text message, and here's some data. This is, well, many of you, your data is in here. So the Pfizer-BioNTech V-Safe data, 12 million people receiving at least one dose, and about 8,000 pregnancies were reported in there. And again, women who are in the high risk, like healthcare workers who are pregnant, may get vaccinated. V-Safe was reporting for all vaccines that about 70% of people said to that question, are you having any pain? They said yes. And then dose 1 and dose 2, you can see that slight increase there in those symptoms that we talked about before. So that is following as well. And same with VAERS. We're seeing that some very few non-serious or very few serious safety events that are being reported out of these millions of doses. So I'm going to kind of go to the end here because I want to take a few minutes for questions. This observation period, if you're going to have anaphylaxis, it is within that red line is 30 minutes, and that's why if you have allergies, we make you wait for 30 minutes, otherwise 15. These are all the things that we're continuing to monitor, and you can see events in the vaccinated, very, very few events that happen in the general population. That's what we're comparing it to, and so that's the beauty of this research. In closing, the doses overall are rolling out. We need more. They've been safe. They've been effective. And the last thing I want to just say is we cannot give up on our masks. We will be wearing masks for a while. And especially there's some advice about double masking with the new variants that are coming in. It's really about the quality of your mask. So physical distancing still works. As you're communicating, try to communicate with kindness, with some evidence, empathy, follow the national laws. Not as helpful as temperature taking, since 56% of people are asymptomatic. Plexiglass doesn't seem to work because it's still circulating around it. And then we were kind of obsessed with wiping down cardboard boxes early on, and that doesn't seem to be necessary. So thank you for your attention, and I will turn it back to you, Angela.
All right. I'm going to run through some quick questions. Can you go back a slide there? One of the questions does relate to masking.
Sure.
There. There is a lot more kind of coming out now about type of mask, double masking, masks with filters, I think specifically in response to the new variants.
Yes.
Can you comment on whether that's something we should be emphasizing to patients or not?
Yes, the quality of the mask really matters. So it needs to be a well-made mask. If it's a homemade mask and you hold it up to the light and you can see through it, it's not adequate. So it needs to be at least 2 layers. It should have a filter. And you can also have, as you can see in this picture, a surgical mask with a tightly woven cloth mask over it is what I'm seeing being recommended by CDC.
Okay. There were some questions about travel requirements that you went through early in the presentation. Do the new travel requirements take into account vaccine status? Or
They do not.
They do not. And the pre- and post-travel testing requirements, does that take into account your vaccine status or not?
It does not. So, but in international travel, we will likely be asked to show our vaccine card. So hang on to that. Take a picture of it.
Quick question. If professional staff at Children's Minnesota have been vaccinated elsewhere at Alina or otherwise, do you want them reporting that to us?
Yes.
How should they do that?
Yeah, so go to applications, drop down to COVID, and then you can put in your, where it was the opt-in. You can also do it on the COVID page. That original opt-in, opt-out, just re-enter your CE number, and there's a button that says, I got vaccinated elsewhere. If you click that, we'll count you.
So we will put those instructions in our follow-up information that we send out after grand rounds. I've heard a lot of worries about not developing an immune response or symptoms after vaccine and people wanting to get antibody tested to ensure that they had an adequate vaccine response. Can you comment on that?
Yes. Yeah, so I think, you know, we have talked about what you may feel like afterwards, and remember that is the minority of people. Majority of people do A-OK. if you didn't have a response, you didn't wake up in the night, you didn't have fever, it doesn't mean you didn't respond. So I had very little response from mine. It might be because I'm old, but it doesn't mean that you won't have measurable protection. It's A-okay.
Okay.
And you don't need to do a lab test. Serology testing is not the most reliable.
Given that we don't yet have information about transmissibility of COVID once you have been vaccinated, would quarantine measures still need to be in place if you've been exposed and you are vaccinated?
So this is a hot topic, quarantine for someone who's been vaccinated. It is actively being discussed at CDC and MDH. Right now, there are no changes. You would be treated as if you didn't have vaccine, but that will likely change. Even going out to kind of immunity for 6 months as opposed to the 3 months we have right now. So no changes at present, but I think it's right around the corner.
There was a question about Children's Minnesota vaccinating adult special needs kids, so kids who qualify for the vaccine who are over the age of 16.
Yes.
Are we going to be vaccinating them at children?
Yeah, so we have a long wish list of people that we want to vaccinate, and children with special needs, children who are in that high risk list, as you can see, are on our wish list. Since we don't have 65 and older patients, our next path forward is not as clear as the adult health system. So I did submit a menu to MDH on who we want to vaccinate, parents of technology-dependent children, et cetera. So we're waiting to hear back from them. I think they're so busy working with teachers we haven't heard. But we do have plans to do that population.
I'm going to get 2 more questions in, and then we're going to call it.
All right.
Tylenol or ibuprofen after vaccine?
It's okay.
Okay.
And not before. Don't pre-medicate. There are some studies, a handful of studies, that it does blunt your immune response. You'd still get protective levels if you do it, but it does lower your antibody response. But afterwards, if you've developed a fever, the checkered flag has already been waved to your immune system to go. So that's underway. It's okay to take, don't suffer. Don't have fever and pain. It's okay to take Tylenol or ibuprofen.
The last question, you presented a lot of vaccine information about the forms of vaccine that we're using here in the U.S. Many of our family members, particularly those who are from Latinx communities, have family members who are in other countries who are getting other vaccines, specifically the Sputnik V vaccine from Russia. Do you know much about the safety and efficacy of those vaccines, or any advice that we could give people who are saying, should my family get this vaccine in other countries?
Yes. I cannot quote anything about the Sputnik vaccine, but I can say that there are dozens, maybe hundreds of vaccine candidates, some of which are being used, some of which were thoroughly studied, some were not. So China and Russia, I'm not sure they finished their phase 3 trials. I would say on that, the best thing to do is to go to the World Health Organization. There is so much information on their website, and drill down to whatever those countries have provided, World Health Organization will post.
Okay. So the WHO is the best source for the other international vaccines.
Yes.
What you mentioned.
Yes,
okay.
That's where I would go.
We are going to stop there because it is after 9 o'clock. I know there are a lot of questions we didn't get to. We will send out the slides to people who joined us today. We will send out information about where to log your vaccine. We'll send out some frequently asked question information. So we'll get information to everyone here. I can speak for everyone listening, all over 430 of the people who joined us this morning, to say thank you, Patsy, for joining us, for continuing to share your expertise with us, and we will get through this.
Yes, we will.
Together.
I want to especially thank the people on this slide here, are the VaxOps leads, so Joe Curlin, Adrian Thornton, Mallory Snyder, Megan Delgado, and I have been leading the whole vaccine operation. So we are a mighty team, and I couldn't do it without them. So lots of people, and IT, Stephanie D'Antoni behind the scenes, so thanks to all of them. Stay safe, everybody. Stay strong. There will be another side.
Thanks, Steph.
Take care.